Unicameral bone cyst. It is usually benign, happens in the first 2 decades. It can cause pathological fracture, especially of the proximal humerus. It is classified into two, active or latent. Active means it is adjacent to the physis. Latent means it is away from the physis. It consists of serosanguous fluid, filled cavity. It is mostly central. It is involving metaphysis. It is mostly lytic and unilocular. A fallen reef sign is pathognomic for a unicameral bone cyst. It's a non-expansile when it's near the physis. That could be a differentiating factor from aneurysmal bone cyst. Some would have educated a rising bubble sign. There is a gas bubble which is moving upward, is also being described. The treatment for such cyst is debridement, intralesional excision with other possibilities like intracystic bone marrow injection, curettage and bone graft, curettage and phenolization with or cortisone injection, or cementing, which cause thermal ablation. Another option can be ethanol injection. 95% ethanol is given, 3 injections are given. And another possibility is X-fuse injection, that is demyelinated bone matrix, which can be injected. There is a scoring system called Neer score for unicameral bone cyst. Type 1 is healed, type 2 is healed with defect, type 3 is persistent cyst, and type 4 is recurrence. There is a genetical translocation 16:20 described, and there is a disturbance bone growth locally, causing blocked venous drainage and increased pressure. The injection of steroids has shown to have mechanical effect more than steroids effect itself. So at the compendium for unicameral bone cyst, the treatment option can be observation number 1. Number 2, you can give injections that can be ethanol injection or demyelinated bone matrix injection or steroid injection or bone marrow injection. A surgery can be done in which you can use bone graft itself, cement, or phenol. Phenol is placed via a technique called pore technique.